All right, good morning everyone and welcome to Department of Medicine Grand Rounds. My name is Neisseria and it is a pleasure for me to introduce our speaker for today, Dr. Jeniel Nett. Dr. Nett is an assistant professor in the Department of Medicine. She completed her bachelor's degree from the UW-Madison, then subsequently completed a residency in internal medicine, a fellowship in infectious diseases, and happened to also collect a PhD along the way, and numerous accolades. She is supported by a K08 and a Burroughs Wellcome Fund. Her area of interest is Candida and biofilm formation, and she has over 40 publications, which is quite a feat for somebody who's only been an assistant professor since 2013. So welcome, Dr. Nett. It's a pleasure for us to have you as our speaker. She's going to be talking about recurrent infections and their roots and when to dig deeper.
Thank you, Matt. I'm happy today to talk to you about, about one of the most common consults I see as an infectious diseases physician, and that is the patient with recurrent infections. And today, what I'd like to do is to provide you with the framework to approach a patient with recurrent infections, and that is to ask and answer the question of why did this patient develop the infection? Can this be prevented? And then also, should I be looking for an underlying immunodeficiency? So I've constructed this diagram to depict some of the causes of recurrent infections. And I'll be showing this throughout the lecture and giving some examples and some cases for each of these. So the major category that we see are anatomic abnormalities in adults. Many of the patients with recurrent infections have an anatomic abnormality underlying why the recurrence occurs. Untreated infections make up a big bulk of patients with recurrent infections. In this category are things like drug-resistant pathogens or atypical pathogens, and also untreated infections because of a nidus of infection. I'll be discussing some primary immunodeficiencies. These are acquired disorders, congenital disorders that predispose patients to recurrent infections. Although very rare in adults, it's important to know when to recognize these, and I'll be giving some red flags about when to think about an underlying primary immunodeficiency. And then secondary immunodeficiencies, much more common in adults than primary immunodeficiencies. These are inherited disorders, and they can be due to underlying illness or medications. This will be a case-based approach. I have 4 cases to discuss to highlight some of the concepts underlying recurrent infections. Then I'll give some future directions and some advancements in looking at the host immune response to pathogens and infection. I'll then end with some pearls on where to look for underlying infections, when to consider immunodeficiency, some red flags. So this is our first case. This is a 45-year-old woman with rapid onset of fever, fatigue for the past day. She now has right lower leg erythema, swelling, and pain. On exam, she's febrile, she's tachycardic, she's not in acute distress. When you examine her leg, it's diffusely erythematous. She's warmth and 2+ edema. On past medical history, she has diabetes, hypertension, obesity, and a history of cellulitis. Looking at her leg, you can see it's quite erythematous. There's edema, and it's painful. So this patient has recurrent cellulitis. This is a deep dermal subcutaneous infection. It's most commonly caused by streptococcal organisms, group A, but group B, C, G, and other organisms can cause this as well. So the questions I have for this case are, why did the patient develop recurrence of cellulitis? What measures can be taken to prevent future episodes? And also, is evaluation for immunodeficiency warranted in this case? So first, why did the patient develop recurrence of cellulitis? We see 2 main factors that really contribute to recurrent cellulitis, particularly in the lower leg. And these are skin integrity disruption and lymphedema or edema. With skin integrity disruption, the barrier of the skin allows pathogens, when it's disrupted, to enter the dermal and subcutaneous tissues. And then when there, with lymphedema or edema, it can replicate basically in the media and resist the host defenses. Looking at patients with cellulitis, a portal of entry can be found for almost 80% of these patients. And maybe not surprising, half of these have tinea as the underlying breach in the barrier. The recommendation is to treat tinea for all patients with cellulitis, and this is based on expert opinion. It's part of the Infectious Diseases Society guideline. There aren't data, but because of the risk factor, it's recommended routinely. While other skin breaks can occur, wounds, ulcers, particularly in patients with diabetes mellitus, trauma or dermatitis, venous stasis dermatitis, for example, and other dermatologic conditions. And it's important to recognize these in the feet, even though you're examining the leg, that this is one of the main areas where the bacteria can enter, and to treat them. So what's the second factor? Edema or lymphedema. Patients that have cellulitis and go on to have a second episode are twice as likely to have chronic edema. What factors contribute to this? Venous insufficiency, saphenous sphenectomy, as we see with patients who have undergone coronary bypass, and prior episodes of cellulitis. These damage the lymphatics and allow for fluid to accumulate. Prior ipsilateral procedure, for example, would be an orthopedic procedure. Lymphatic disruption. There are various factors here. This can be congenital. It can be due to an injury or from lymphadenopathy. And then obesity can contribute to edema and lymphedema. So it's recommended to manage edema and lymphedema to prevent future episodes of cellulitis. And this can involve elevation of the leg. It can involve compression stockings or mechanical compression, diuresis in some patients. And the Red Legs program in the UK has looked at the effectiveness of this and what it can do for a community. Here they decreased cellulitis episodes in this patient population sixfold, and this resulted in hospital savings of approximately, for every dollar they spent on lymphedema, they saved $100 or pounds, because it was in the UK, on hospital costs. And they reduced admissions by 90%. So the next question I had was, does recurrent cellulitis warrant evaluation for primary immunodeficiency? What I've told you is that the risk factors for cellulitis are primarily anatomic, treating the tinea for the skin breaks and treating lymphedema. Workup for primary immunodeficiency is rarely needed for patients with recurrent cellulitis. Routine HIV testing is recommended for patients with recurrent infections, including cellulitis. And when would you consider, should I evaluate for primary immunodeficiency? Well, really, it's multiple atypical sites to think about. And what's an atypical site? That's anything other than the lower leg. So facial cellulitis or another area, consider, is there some underlying immunodeficiency, especially with multiple occurrences and no clear etiology. And in particular, one thing to consider in adults, is there a new onset neutropenia? Because neutropenia can predispose to this. And considering making sure that there's a CBC with differential that's updated in these patients. Well, when should you consider a primary immunodeficiency? Most of the primary immunodeficiencies that result in recurrent cellulitis involve granulocyte abnormalities, and these patients develop recurrent infections very early in life. So if you're seeing a patient that has had recurrent infections beginning in childhood, it would be important to consider this. But for adults, generally there's not an underlying primary immunodeficiency. The other point I'd like to make is that a lot of these patients can benefit from suppressive antibiotic therapy, and particularly those patients that the tinea and other skin factors have been managed, they're still having lymphedema, or if they're having cellulitis with the lymphedema being managed as aggressively as possible. And that is a consideration and something that we see patients in infectious diseases clinic for a discussion about. So I've given you some examples of anatomic abnormalities that account for cellulitis. And I'd like to discuss a few other recurrent infections that involve anatomic abnormalities. So looking at urinary tract infections and what predisposes to recurrence of these, we see urinary obstruction, reflux, and abdominal abscess. Diverticulosis and inflammatory bowel disease can predispose. Subcutaneous abscess, and particularly in the same location, should lead you to think about an anatomic factor. This could be a foreign body or a cyst, like a pilonitis cyst. Cellulitis, as I've told you, lymphedema and skin breakdown or tinea contribute. Sinusitis, the factors here contributing, nasal polyps, deviated nasal septum, or prior facial trauma. Pneumonia, and this is pneumonia in the same location, the same pattern. Looking for obstruction, tracheal or bronchial obstruction. Is there mediastinal lymphadenopathy? Does the patient have a post-obstructive pneumonia with a neoplasm? Is there a retained foreign body? Or is there aspiration? We see this commonly where patients will have an anatomic abnormality and have recurrence of aspiration and recurrence of pneumonia. Cholangitis, looking for biliary obstruction. And the majority of these recurrent infections don't need further evaluation for primary immunodeficiency because there are anatomic factors that underlie the cause of these. I will just point out, too, sinusitis and pneumonia. And there are patterns of sinusitis and pneumonia where you'd really think, could there be a primary immunodeficiency? And I'll be giving some examples of these later and some red flags on when to consider primary immunodeficiency for these infections. So we have our second case here. This is a 63-year-old woman. She has 4 weeks of left facial pain. She has fever, fatigue, nasal congestion, and postnasal drip. She's received courses of antibiotics, amoxicillin clavulanate, and doxycycline. She had very minimal improvement with the antibiotics, and she now has persistent symptoms and purulent nasal drainage. On exam, she's febrile. She has tenderness over her left maxillary sinus, and her nasal mucosa is diffusely erythematous. On past medical history, she has hypertension, allergic rhinitis, and she's had sinusitis approximately 3 to 4 times per year for the last several years. So this patient has recurrent acute bacterial rhinosinusitis. She has a CT scan which shows left maxillary and ethmoid sinusitis. The questions I have for this case are, why did the patient develop recurrence of sinusitis? And also, should she be evaluated for immunodeficiency? Well, first, why did the patient develop recurrent sinusitis? Well, ultimately, she was referred to ENT, and she underwent endoscopic evaluation with cultures performed growing Pseudomonas aeruginosa. And here what we see is the antibiotics that are commonly used for community-acquired sinusitis are not effective against Pseudomonas aeruginosa. So she had a pathogen that was untreated. And she falls into this category of untreated infections underlying recurrence of infections. I'll also argue that she probably has anatomic factors contributing. She has allergic rhinitis, she may have nasal polyps, and it's probably a combination of things. So looking a little bit deeper at this untreated infection category, and what's in this category? Well, it's composed of a few things. First, antibiotic resistance. And this can be resistance to a specific antibiotic that's being used, or it can be an atypical pathogen not covered by the antibiotic that you're using. An example we see often is urinary tract infection, where a patient goes into an urgent care with urinary symptoms, a urinalysis is performed, the patient's given an antibiotic for urinary tract infection, but maybe it's not effective against ultimately the bacteria that grows. Another example is abscess. Some of these can be difficult to drain. Maybe drainage is not warranted at the time, and the pathogen's resistant to the antibiotic that's prescribed. Another example is sinusitis. I showed you the example of Pseudomonas. Well, it's sometimes difficult to have obtain these cultures for sinusitis. So it's quite common that you may see an atypical pathogen. In addition, patients are at risk for these if they've had multiple courses of antibiotics. So our patient had seen antibiotics at least 3 to 4 times a year for sinusitis, and then ultimately developed a bacteria that was resistant to the commonly used regimens. So another big category in this untreated infections is nidus of infection. And this is basically an infection that you're not able to treat even with the appropriate antibiotics. The example I like to use here is infected renal calculus. So when patients have a renal stone and it becomes colonized or infected with a pathogen, it's very difficult to clear that infection. The pathogen remains on the stone even despite appropriate antibiotics, even ones that it should be susceptible to. And with that, they can develop recurrence of infection. Another example is chronic prostatitis, where it's difficult to eradicate bacteria in the prostate. And then here, patients go on to develop recurrent urinary tract infection due to the prostatitis. And of course, considering is there a foreign body, because bacteria can adhere to foreign bodies and are very difficult to eradicate. This can be in a subcutaneous infection in a variety of different areas. And what you'll probably see is that a lot of what I'm discussing in this nidus of infection overlaps with anatomic abnormalities. So when there are anatomic abnormalities, there can be conditions where bacteria can persist and not be cleared by antibiotics that should be appropriate for the infection. The next category I'll discuss here doesn't fit exactly in untreated infections, but I thought it could sort of fit the best here, and that is colonization with the virulent strain. And patients can become colonized with a virulent strain and develop recurrence of infection. An example is community-acquired MRSA. Here we see patients develop recurrent skin and soft tissue infections with MRSA, even with healthy immunity. And they're really not able to clear these infections, and they persist. The reason is that strain is so virulent. So the USA 300 strain is an example of this. Another example is group A strep pharyngitis, where patients will have a virulent strain and have multiple episodes of streptococcal pharyngitis related to the virulence of the strain. Another example is probably Clostridium difficile, where patients have recurrence of Clostridium difficile due to a particular virulent strain. Well, of course, many factors are involved there. So going back to case 2 here, the patient with recurrent acute bacterial rhinosinusitis due to Pseudomonas. She responded to a treatment course with ciprofloxacin, and then she was ultimately evaluated and managed for allergic rhinitis, which was probably one of her underlying factors. So looking at untreated infections and just some take-homes from this is quite common in patients, and to consider this as a reason for recurrence of infection. One thing to ask is, do you have the correct pathogen? This can be difficult if cultures are not able to be easily obtained, sometimes with abscesses, or sometimes, for example, sinusitis. Is there a nidus of infection that you're not treating? For urinary tract infections, looking for stones and other causes. Or could this be a virulent strain, frequently seen, as I told you, with MRSA? So moving on to our third case. This is a 32-year-old woman with cough, fever, and chest pain for 2 days. On exam, she's febrile, tachycardic, respirations are 22. She's in no acute distress, alert, appropriate, she's tachycardic, she does not have murmurs, and she has decreased breath sounds on the left. She tells you in her past medical history that she's had pneumonia twice and sinusitis 3 times, all just in the last 2 years. A chest x-ray is performed, which shows this left-sided infiltrate, and a sputum culture is growing Streptococcus pneumoniae. This patient has recurrent bacterial pneumonia. And to remind you, she did have multiple episodes of pneumonia and sinusitis in her past. So the questions I have here are, should she be evaluated for primary immunodeficiency? And what primary immunodeficiencies present in adulthood? And here I'd like to move to the smaller category of the congenital primary disorders that are seen in adulthood. Although not very common, it's important to recognize when you would consider these and some red flags to evaluate. So looking at primary immunodeficiency, the congenital disorders, there are approximately 1 in 2,000. And this is all comers, children, and adults, an approximation. And this group is comprised of approximately 150 different diseases. The genetic abnormalities are known for some of these, but not all of them. In adults, common variable immunodeficiency is the most common, as its name suggests, and it's 1 in 20,000 to 1 in 30,000 patients. I'll be discussing more about common variable disease. Now, there are some that are less commonly diagnosed in adults, and these are really quite rare. A lot of them are diagnosed more in children. For example, chronic granulomatous disease, more common in children. There can be variants that are later in life. Cystic fibrosis, occasionally there are variants that are later in life, but really a lot of these are diseases diagnosed earlier. But just to be aware that there are ones outside of common variable immunodeficiency that can be diagnosed in adulthood. So what is common variable immunodeficiency? It's basically a group of disorders that all have poor B-cell differentiation, resulting in poor antibody response and low immunoglobulin levels. And this is a heterogeneous group of patients and a heterogeneous genetic makeup. For what's known about the genetic diseases, they're from various different pathways. And the clinical presentation, as the name suggests, again, is variable. What is common is that patients have recurrent infections with pneumonia, bronchitis, gastrointestinal disease, or sinusitis. What's also common is that many of them have autoimmune disease, approximately 30% having some autoimmune component. They have an increased risk of malignancy beyond the general population. And they also develop granulomas throughout the body, approximately 10 to 20% of patients. How is this condition diagnosed? It's diagnosed with low antibodies, low IgG is needed, and then either low IgM or low IgA. And sometimes it can be both. In addition, they need to show that they do not mount an appropriate antibody response. And this is generally done with vaccination to pneumococcus and measurement of antibodies after. They also have no underlying etiology for their hypogammaglobulinemia. And is there treatment? The treatment is IVIG. And this can be very helpful for decreasing the recurrence of infections. And so it's important to recognize these because there are treatments that can be very important. Although the IVIG doesn't seem to have an effect on the risk for malignancy or the autoimmune disease. These data are taken from a cohort of approximately 2,000 patients in Europe. And what they looked at was the age at the time of diagnosis for common variable immunodeficiency. What you can see is that early in life, there actually is a male predominance of this disease. And this is due to an X-linked disorder, a subset of patients that present very early with recurrent disease and recurrent infections and diagnosed early. But what you notice is that throughout later childhood, early adulthood, later adulthood, there's ongoing diagnosis of this infection. And it's in an equal male to female predominance. What the authors also note here is that there's quite a delay to the time of diagnosis. In this study, it was approximately 4 years from the first symptoms until the patients were diagnosed. But other studies have shown 10 years, for example, of how long it takes to diagnose this disease in adults. And part of it is not recognizing that primary immunodeficiencies can present later in adulthood. What infections do these patients get? These data are taken from Mount Sinai Immunodeficiency Clinic, approximately 250 people. And here what they noted was that the majority of these patients have recurrent bronchitis, sinusitis, or otitis. So recurrent infections in the respiratory tract. And the otitis was primarily in children. So it was 98% of patients had these. You also see pneumonia was common, bacterial pneumonia, 76% of patients. See, herpes zoster was seen. What I'll point out, too, is the gastrointestinal pathogens, Giardia, Salmonella, Campylobacter, seen as either recurrent or persistent infections. We also see infections from encapsulated organisms and Mycoplasma pneumoniae. I told you that patients develop autoimmunity and other non-infectious complications with common variable immunodeficiency. And these data are taken from approximately 1,000 patients in a European cohort with common variable immunodeficiency, looking at what other clinical manifestations do they have. And autoimmunity comes up very high, 30% here. Rheumatoid arthritis, hemolytic anemia, thrombocytopenia, pernicious anemia, autoimmune thyroiditis, and vitiligo. We also see splenomegaly and bronchiectasis as being common. The bronchiectasis is thought to be related to the recurrence of the respiratory infections. Granulomas fall into this category of patients with common variable immunodeficiency. These are non-caseating, and they can be confused with sarcoidosis or other conditions. They often involve the lymph nodes, spleen, liver, but can be found throughout the body, intestine, brain, eyes, and skin. We also see enteropathy associated with common variable immunodeficiency. Approximately 10% of the patients, and these patients have diarrhea, malabsorption, weight loss. And then, of course, the higher risk of malignancy with solid and lymphoma. And this is thought to be due to altered immune regulation. So when should we look for common variable immunodeficiency and other primary diseases in adults? It's really based on expert opinion, and one of the guidelines I found was from the European Society for Immunodeficiencies. So I thought we'd go through these individually. 4 or more infections requiring antibiotics within 1 year, such as otitis, bronchitis, sinusitis, and pneumonia. And I thought that was a really excellent one. We saw 98% of the patients had recurrence of these infections, so it makes a lot of sense. One thing I would point out, though, is that a lot of times people are given antibiotics for non-bacterial infections, and that if the patient received 4 courses for what might have been a viral infection, then maybe that's not the best marker for evaluating for primary immunodeficiency. Looking at the next one, recurring infections or infection requiring prolonged antibiotic therapy. Recurrent infection seems appropriate for many of the infections, but then a prolonged course, I thought, well, that's a lot of times endocarditis, osteomyelitis, which may be related to diabetes, and it didn't really make a lot of sense that fell into the category for me in particular as an infectious diseases physician. Looking at the next one, 2 or more severe bacterial infections, osteomyelitis, meningiditis, septicemia, cellulitis. Well, I've told you before, cellulitis, mostly the risks are anatomical, and it'd be really quite rare to have a primary immunodeficiency. Of course, meningitis, you'd be concerned. And osteomyelitis, we see this in patients with diabetes mellitus or vascular disease as really some of the underlying etiologies. Another one, 2 or more radiographic proven pneumonias in 3 years. Infection with an unusual location or unusual pathogen, or primary immunodeficiency in the family. And that's an important consideration because these are inherited disorders. So my question overall was, how well do these guidelines work? For example, I think almost everyone I see in clinic would fit these guidelines, and we know that primary immunodeficiency is really quite rare. So I was happy to find this study that looked at how effective these guidelines were looking for primary immunodeficiency. And this study was done in Turkey. There's 3,500 patients in one of the clinics in Turkey. And what they did is they put those 6 guidelines, those 6 questions, on their initial intake. So when patients just coming into the clinic, those were part of their routine questions that they were asked. And these patients were coming into the clinic for any reason. Some were for recurrent infections, some were for non-infectious complaints. And they just said, how many people will answer yes to any one of these questions coming into the clinic? And over 230 people had a yes to one of these questions. They then looked through their patients and said, well, how many of these patients have an immunodeficiency? And they found that 24 of the 3,500 had an immunodeficiency. And of those, as you might expect, common variable immunodeficiency fell out as the most common at 50%. Then they looked, well, do these conditions, does this overlap? And they found 20% of the people who are diagnosed with primary deficiency had answered yes to one of the questions. So even with those questions being very, I would say maybe vague, they were able, they missed 4 of them, basically. And those patients had gastrointestinal manifestations or dermatologic conditions. And then looking at it the other way, 230 people had one of these warning signs, and only 10% of them were viewed by the physician as needing a workup for immunodeficiency. So I thought that was a very interesting study looking at those guidelines. And I'll provide some red flags and ways I consider those guidelines later. But going back to our patient, she had recurrent bacterial pneumonia. She underwent workup with a CBC with differential and a negative HIV test. Then ultimately, her immunoglobulin levels were checked to evaluate for common variable immunodeficiency. And you can see here that she fit criteria. She has a low IgG, she has a borderline low IgM, and a low IgA. She also underwent vaccination with pneumococcal vaccine. The antibody response was measured as low, which fits in with the criteria. And then she was referred for management with IVIG, and pointing out again that it's important to recognize this patient because there is an effective management that can be helpful for recurrent infections. Moving on to the next case. Case 4, this is a 20-year-old female. She's presenting with fever to 103. She has a mild headache, fatigue, rash, and joint pain. On exam, she's febrile, she's tachycardic, blood pressure 97/55, respiration's at 16, she's not in acute distress. Her neck is supple, she does not have lymphadenopathy. Her lungs are clear, she has no murmurs. She has this non-blanching rash that I've shown you a picture of. She has no synovitis or no focal neurologic defects. Laboratory findings, she has leukocytosis with bandemia. Her urinalysis is negative. A chest x-ray is obtained, which is negative as well. In her past medical history, she's had tonsillectomy and she had meningitis as a teenager. Her admission blood cultures ultimately grow Neisseria meningiditis, serogroup B. And she has recurrent Neisseria meningiditis infection. Her prior episode of meningitis was found to be due to this as well. So the question I have on this case is, how common is recurrent Neisseria infection? And should she be evaluated for immunodeficiency? These data are taken from the CDC, looking at the incidence of Neisseria meningitis infection. And over the last 15 years, the incidence has declined. And I've marked when the conjugate vaccine, the quadrivalent, was available and recommended in around 2006, and then when the booster was recommended. Looking at the most recent data on the CDC website, we're from 2014, showing 450 cases in the U.S. So what immunodeficiencies have been associated with Neisseria infection? Low complement has been associated, and this can be either in the setting of primary immunodeficiency, inherited disorders, or secondary immunodeficiencies, patients with lupus, for example. So what complement deficiency is associated? It's terminal complement, and this is a factor C5 through C9. And these factors, after complement activation, can form a pore on the surface of bacterial pathogens, allowing for lysis of the bacteria and control of infection. And this has been found to be important for Neisseria infection and clearance, and particularly in patients that don't have good immunity induced by vaccination. So how do these patients present? They usually present later in childhood or early adulthood, when patients would have more risk factors for Neisseria meningitis. And the mean age in this study was 17. It's really quite rare, 3% of all primary immunodeficiencies. During outbreaks, it hasn't been shown to be very common. But in sporadic cases, in some patient populations, it can be 50% of patients that have primary immunodeficiency as the reason why they developed Neisseria infection. What's interesting as well is that these cases for patients with primary immunodeficiency are usually quite mild. So for our patient, she didn't have meningitis, she looked well, and it's because the immune response isn't as robust. How are they diagnosed? With a total complement level, so CH50, and most often patients will have a CH50 of 0. And with abnormalities, it can be evaluated for the individual components, so C5, 6, 7, 8, 9. what's the management here? Vaccinations are key. We now have a vaccine for serogroup B. Education for the patient, knowing that they're at risk for this infection, if they have fever or a rash consistent with Neisseria, that they should be evaluated promptly. And then screening of family members. These are inherited disorders, so siblings can be checked, and if positive, they can undergo the education and the vaccination earlier. Going back to our case here, it's a patient with recurrent Neisseria infection. Her CH50 was 0. The C7 was undetectable. She underwent vaccination for Neisseria meningiditis serogroup B, the one not covered in the quadrivalent vaccine that's recommended. And then she also underwent screening of the family members, with one sibling being positive. So I talked about Neisseria infection partially because of the immunodeficiency that can be recognized and present in early adulthood, but also because of the outbreak that we had on campus. And this outbreak, as you probably heard, involved 3 undergraduate university students. And these students were found to have the identical isolate of Neisseria meningiditis that was the serogroup B. They didn't have known exposures to each other, and it was thought that this might represent the beginning of what could be a very big outbreak. So there was a major effort to vaccinate the undergraduate students and others at risk. And with this effort, almost 70% of the targeted undergraduates were vaccinated. They received the vaccine in October, most of them in October of this year, and the vaccine is part of the 2-dose vaccine, with the next dose being due 30 days approximately after. And I'm bringing this up because they're asked to present to their primary care clinics for the second dose of the vaccine. The first dose was provided through the university. And they might be coming to your clinics. So to be aware that they were vaccinated for the serogroup B, and the doses are in the Wisconsin Immunization Registry. And they're encouraging everyone to enter the second dose in the registry as well. So I've told you about primary immunodeficiencies being quite uncommon, given you 2 examples, common variable immunodeficiency and complement deficiency. And now what I'd like to do is switch to secondary immunodeficiency. These are acquired disorders and involve primarily medications and illnesses, much more common in adulthood than primary immunodeficiency. So one of the important subsets of this are medications. Chemotherapy, of course, a major immunosuppressant. And some of the chemotherapy regimens can have immunosuppressing effects for quite a long time after they're given. So, for example, fludarabine, where the effect can be over a year after. So considering patients' past medical history and medications they've received, not even that recently. Immunosuppressants. Patients are on various immunosuppressants for rheumatologic conditions and evaluating, giving a close history of that. For example, steroids, having been on more than 10 milligrams of prednisone or the equivalent, can place patients at risk for infections. One of the categories in the immunosuppressive category I want to take note of particularly is TNF inhibitors. Patients receive these for a variety of autoimmune and rheumatologic conditions. But what's important to note about these is that some of them are given once a month and maybe by injection. The patients may not consider them one of their normal medications. They might not list them as a medication, and it may be listed in the computer record separately. Transplant medications. At UW Health, their website shows over 12,000 transplants have been performed. I'm sure it's higher by now. And these patients will be presenting to various clinics. Some of the medications for transplant can be immunosuppressive for quite a long time. For example, therapies given for induction prior to transplant, or if the patient has rejection, they're given a serious immune suppressive medications. And just to be aware of the impact of some of those medications. And then a category I'd like to talk about here is drug-induced neutropenia, which isn't that common, but it's important to consider, and that's particularly in patients that have recurrent skin and soft tissue infections or an unusual cellulitis. Some of the medications have known risk factors, for a known incidence of this. Clozapine, sulfa drugs, including sulfasalazine, have a known risk. One is rituximab that I wanted to discuss. this is a quite high risk, 6% of patients developing neutropenia. But what's interesting is this can occur months after, 6 months after the patients can develop the neutropenia. And they might not offer that they've had that medication recently. It may not be something you're thinking about because of how long this duration is. And of course, HIV screening, as I mentioned earlier, it's important to do the routine screening for HIV, and of course, additional screening for risk factors, and if they have a infection that you would consider HIV, recurrent thrush or pneumocystis are just some examples. Metabolic diseases can predispose patients to infections. Diabetes mellitus, could the patient have a new diagnosis of diabetes mellitus? Do they have uncontrolled diabetes? Liver disease, do they have underlying liver disease that has not been diagnosed yet? And uremia, and treating these underlying illnesses. Protein loss and malnutrition is an important category here. Some examples: nephrotic syndrome, enteropathy can have low IgG, leading to recurrent infection. Malignancy is important to consider. Does the patient have a new malignancy? Could they have new neutropenia? Looking for CLL, AML, multiple myeloma, are just some examples, but much more common in adults than the primary immunodeficiencies. Do they have low complement levels? I gave you the example of the primary immunodeficiency, but some illnesses can have low complement. For example, lupus and vasculitis. And these patients are at risk for Neisseria and other infections. And the category of hyposplenia. Of course, patients with splenectomy, we know they have impaired immunity to encapsulated organisms. But there are illnesses that have low spleen function. Just some examples here: hemoglobinopathy, celiac disease, IBD, and Whipple's disease. So I'd like to switch now to just some future directions and where this immune infectious area is headed. This is a study looking at the host genetics related to Staphylococcus infection. This study included 50,000 patients, about 5,000 which had had Staphylococcus aureus infection. And what they did was look for genetic components that may predispose patients to Staphylococcus aureus. What they found was that there are 3 single nucleotide polymorphisms in a gene HLA2 that was associated with the risk for Staphylococcus aureus infection. And of course, this is a disease we don't think necessarily of being due to an immunodeficiency. What it's thought is that the defects and the abnormalities in HLA might allow for altered peptide presentation, and that then it wouldn't be recognized the same way. What's interesting about this gene is that it's been shown to influence other infections as well, including Staphylococcus, where different haplotypes are linked to different risks of carrying Staphylococcus aureus in the nasal area. And also for Streptococcus, different haplotypes predisposed to infection, and then they also allow for different immune response, where some haplotypes have a very robust immune response and some would have less. Looking at some of the recent studies, you can see many polymorphisms are linked to infectious risk. Here, polymorphism in ILL4, a risk to Clostridium difficile, not something we normally consider to be in only immunodeficient patients, of course. And then MR1 for tuberculosis, a disease known to affect a whole variety of patients. What I've shown you earlier is that there's just really this small subset of primary immunodeficiency cases, that is, inherited disorders that predispose to infection. But as we learn more about the human genome and are able to do these studies, what we'll probably find is that this is actually probably a larger component, where we'll see a lot of inherited disorders predisposing to infection. And some questions I'm hoping we can answer with more personalized medicine is, who will benefit most from some of our interventions? Are there people that would benefit most from prophylactic antibiotics for cellulitis or for IVIG and for various interventions? Is there a way that we can prevent recurrent disease knowing the genotype of the patient? Is there a way we can prevent some of the initial diseases? And then is there a way we can target vaccines better? So now let's switch to some pearls and some take-home points regarding the workup and evaluation for recurrent infections. What I hope I've shown you is that anatomic abnormalities and untreated infections really count for a lot of the recurrence in adults. And these diseases and recurrent infections don't often need a workup for underlying immunodeficiency. These include skin and soft tissue infections, sinusitis, abdominal abscesses, cholangitis, and urinary tract infections. And these all have underlying anatomic abnormalities, or maybe there's a persistent nidus of infection. I'm looking for atypical pathogens, resistant organisms, the nidus of infection, or other anatomic factors is the workup. In terms of secondary immunodeficiencies, these are quite common and way more common than primary deficiencies. Routine HIV screening, making sure that this is up to date. Medications, considering the medications people are on if they're immunosuppressive, what have they received recently, or could they have a side effect from a medication? And I'd given the example of the drug-induced neutropenia. And then do they have other risk factors for secondary immunodeficiency? And this can be based on the history, the physical, and other family history. And one important consideration I just want to mention again is considering malignancy and new onset neutropenia for patients with recurrent skin and soft tissue infections and unusual infections. Well, when should we think about primary immunodeficiency? Recurrent bacterial pneumonias, particularly if you don't have an underlying etiology, maybe not patients that they're aspirating, but bacterial pneumonias in otherwise healthy people. Recurrent bacterial sinusitis, in particular if they don't have underlying risk factors, patients that don't have allergy, patients that don't have nasal polyps. Recurrent Neisseria infections, really quite rare, but it is important to consider could they have low complement levels because there is treatment. Recurrent and persistent gastrointestinal infections. Campylobacter, Giardia, Cryptosporidium fall into this category. And then in terms of skin and soft tissue infection, really multiple skin or soft tissue infections at different atypical sites. Patients that are developing these, and not just in the lower leg, considering the primary immunodeficiency. Common variable immunodeficiency, the one you really need to think about in adults with these patterns, it's often associated with autoimmune disease. So if the patient has autoimmune disease, having this be a trigger for, well, maybe there's something else underlying the recurrent infection. And then, of course, the family history, these are inherited disorders. So if the patient gives a strong history of autoimmune disease or a history of primary immunodeficiencies, taking that into consideration. And with that, I'd like to thank you for your attention, and I'd be happy to take any questions. Yes?
Very nice presentation and very timely. Question for you on your case one. I recently heard the recommendation on infectious disease about treating tinea or fungal infections currently with cellulitis. I'm not sure about that.
Thank you. So the question is regarding the case one, the patient with cellulitis and the recommendations for tinea treatment. And so the IDSA guidelines do have a recommendation to treat underlying skin infections such as tinea to prevent future episodes of cellulitis. So that would be a routine recommendation for tinea treatment for cellulitis, as well as other underlying dermatitis that may predispose.
I thought I understood you to say that we should routinely, automatically treat whether or not we see or document the infection. Is that right?
I don't know that the recommendation was in the setting of cellulitis. So I'm not sure if there's a routine one for tinea outside of that. It seems.
Cellulitis that we prescribe antibiotics for cellulitis should automatically treat fungal infection, whether or not we document.
I guess if there's a suspicion for fungal infection, so if on your exam you see that there's some flaking or some abnormality that makes you think that they have the superficial fungal infection, I don't think you actually have to have the culture growing in order to do the treatment. We routinely do that if it's suspicious. If the patient does not have evidence of any abnormality, then you wouldn't need to do the treatment. But if it's suspicious, then to go ahead and treat for the tinea. Does that answer your question? Yes. Yes. Yeah, thank you very much. That's an excellent point, and I didn't emphasize that enough in the case. I showed a case of bacterial rhinosinusitis, and it was documented by ENT. But the important point is that most of these are not bacterial. Most of these are viral, and it's important to consider that. And that often antibiotics are not needed in their guidelines for when they are needed. And then the case it's kind of an unusual case because it was drug resistant that was treated with ciprofloxacin, but that wouldn't be standard treatment. So thank you. Yes?
That was great. Thank you. Very relevant and practical. So for those of us in primary care who are thinking now more about this possibility in our patients with recurrent infections, would we send just serum immunoglobulins? Are there other tests you recommend us to send for those patients who are experiencing diagnosis?
Yeah, thank you. So for the initial diagnosis, for some of the red flags with the recurrent pneumonias, recurrent sinusitis, the question is where do we do the workup? Where do we start? So starting, of course, with the CBC with differential routine HIV screening, and if you're concerned about the common variable immunodeficiency, quantitative immunoglobulins would be the way to start, measuring IgG, IgM, and IgA. And with abnormalities there, looking at either probably a referral or looking at the response to pneumococcal vaccine. Questions? Okay, thank you.